morning, everyone. You are welcome to my presentation on chest pain and acute coronary syndrome. I'm Dr. ADEFILA, a consultant physician and cardiologist with CardioCare Multispecialty Hospital. Okay. The lecture is brought to you by the LIMI Hospital Systems. We are the CardioCare Multispecialty Hospital at Area 11 Gariki. Other hospitals are listed. Our vision is to empower Africa through a healthcare ecosystem for training, research, and service delivery. Now, this presentation will be using interactive polls, so you should visit this website so that you could participate in the poll. So this is just telling you about our hospitals in the LIMI hospital system. And this is CardioCare. We are located at 5 Giza Close, Area 11, Gariki, Abuja here. So now on my presentation, the aim of this is to understand chest pain and the causes, to detect conditions that are really hazardous to health, causing chest pain correctly and promptly, to treat disease and causes and prevent complications. So we'll start with the first case. Now, the first case is Mr. AJ, a 24-year-old male who presented with insidious, non-radiating, waxing and waning chest pain, was aggravated by body positions when he raised his arms or tried to do stretches. He gets the pain, and there was also a history of cough. There were no significant relieving factors, so though he tried paracetamol, the pain lasted for hours after onset. It was moderate in intensity. He had a similar pain 2 months earlier after an upper respiratory tract infection. He's not a known hypertensive or diabetic. He has no issue of dyslipidemia. He's a social drinker, and he also takes occasional marijuana and smokes. When he was rushed into our emergency, the vitals were a pulse rate of 106 beats per minute, a bit fast. The blood pressure was 146/76. The jugular venous pressure was not raised. The heart sounds were normal, first and second. Respiratory rate was 20 cycles per minute. Oxygen saturation at rest in the room here was 98%, and the chest findings were normal. So the first poll comes. So what kind of chest pain do you think this patient I just presented as? Typical chest pain, atypical cardiac chest pain, non-cardiac chest pain? I don't know. So that's another option. So we'll just wait 4 seconds and see what the poll is going to say.
Great. Let's try. Try, scan the QR code, and then try, and we will not know you know who answered what. So you can answer freely. Please try, make an attempt.
I think we close the poll now. Or wait a bit.
It's up to you.
So I think we could close the poll. We have a very good spread. About a third thereabout thinks it's non-cardiac chest pain. A third thinks it's atypical chest pain. So I think we'll close the poll now. Thank you very much. That's a very good one. So chest pain I got already. Now, chest pain is a common symptom that bring patients to the emergency. In the Western world, up to a third or 1/4 of patients coming to the emergency may present with chest pain. If it is cardiac chest pain, it has a characteristic, and this is very important for this presentation. The typical cardiac chest pain comes with these 3 criteria: presence of a substernal or retrosternal chest pain, sometimes left-sided. Sometimes they don't describe it as chest pain, but a discomfort. This is usually precipitated by exertion or emotion. And discomfort is usually relieved by rest and or use of nitroglycerin. But for us to say this is typical chest pain that is related to the heart, we need 3 of these criteria. If a patient has just 2 of these criteria, we say they have atypical chest pain. And if you have one of them or none, we say it's likely non-cardiac chest pain. We're going to be referring to this later. So for chest pain history, for the typical cardiac chest pain, it's usually retrosternal or cordial, aggravated by physical or emotional exertion, relieved by rest or nitroglycerin. Depending on the cause, on the stage you are picking, maybe an ischemic heart disease, duration of pain may be less than 5 minutes, but maybe as much as 30 minutes in a patient, for example, in a patient with acute myocardial infarction. Especially in acute myocardial infarction, you may have diaphoresis, feeling of impending doom. Patient presents with also dizziness, syncopal attack. Importantly, the background history, they will have cardiovascular risk factors like type 2 diabetes, hypertension, dyslipidemia. But if you have the following characteristics, the pain is less likely to be from the heart. Note the word less likely. We are not saying patients cannot present with some atypical symptoms, but generally we say when you have these characteristics, it's not likely to be from the heart. So when you see a patient presenting with very sharp pain, then 2 fingers to a particular point cause where the pain is. Sometimes this patient come to you with pain and point to below the breast and say, oh, this is just below my breast. The pain lasting few seconds or hours in a day. Patient with focal tenderness, we used to say when the pain is reproducible with touch, that is, the patient is pressing on the chest and they're getting the pain, we say, oh, this is likely, less likely to be from the heart. Any pain that is posture related or food related, and patient with no known cardiovascular risk factor, we say the pain from them that they are presenting with is less likely from the heart. So there is what we call a pre-test criteria. When a patient comes to you, you want to know if they have a background history that will make whatever symptoms they are presenting with to be related to a cardiac chest pain. Hypertension, diabetes, history of smoking, previous history of atherosclerotic cardiovascular disease like stroke, previous myocardial infarction or peripheral artery disease, family history of ischemic heart disease, especially in young age, less than 40 for most people. So if they have 2 or more of these cardiovascular risk factors, except if it's diabetes or previous cardiovascular disease, you will say, oh, this person is high risk. So if they are coming with chest pain, even if it's atypical chest pain, you will not dismiss such patients. You have to evaluate further. If they have intermediate risk, maybe just 1 cardiovascular risk factor, low risk, they have no such risk factor. So this helps you in making decisions as to what to do next for the patient. So we have our own algorithm at CardioCare. Generally, the first thing is for every patient that comes to the emergency with chest pain, it's a gold standard that you do an ECG within 5 to 10 minutes of presentation. Then you do a quick clinical evaluation, which includes your brief history and exam, and you do a cardiovascular risk profiling, including knowing what their cardiovascular risk factors are and checking basic tests. So if they are high risk, as I said earlier, 2 or more risk factors, if they have an abnormal ECG, that's obvious. You have to get a cardiac troponin and know what's going on. If they have a normal ECG, because they are high risk, you still have to go ahead and get an echocardiogram and their troponin. If the troponin becomes positive or the echo is showing regional wall motion abnormalities, we admit such patients, do a coronary angiogram, and if we have a definitive diagnosis of acute coronary syndrome, we treat appropriately. Now, on the other hand, if they are intermediate risk, if they have an abnormal ECG, we still have to do an echocardiogram and a troponin. If it's positive, we'll go to the extreme end, which is evaluate them further and get an angiogram. But if it's negative, because they are intermediate risk, we check their pretest probability. Now, there are various scores for checking pretest probability. Most times they look at the age of the patients, the characteristics of their pain, Is it typical or atypical? If you are thinking this person has a high pretest probability for coronary artery disease, you go ahead and get an echo. If the echo is suspicious, we look at regional or motion abnormalities. You go straight to the coronary angio. But if they still have an intermediate pretest probability, you have to do a stress test. Now, we have various types of stress testing depending on various criteria that may not fit this presentation, but the most common is usually the exercise stress test. If it's positive, we go straight to a coronary angio. If it's negative, we'll go back to pathway 1, which is this, we're thinking is likely a non-cardiac cause, and we can exclude other causes of their chest pain. If the pretest probability is low, we go to pathway 1, which I'm going to talk about later. For no patients that come with no known cardiovascular risk, if they have an abnormal ECG, we check for their troponin. If it's positive, we have to do a coronary angio. If it's not positive, we have to exclude non-cardiac cause. We are going to talk about those causes later. If you are not sure and they still have ongoing chest pain, you may still check the troponin again. If it's negative, exclude other causes. So this like an algorithm that we use in CardioCare to try to know.
You will find this algorithm within your time is already fast spent.
Okay.
You will find the algorithm in your books, in your jotters. So if you check your jotter, one of the pages there, you find the algorithm that you can use over and over again in your clinic. So check your jotters. That's why I say you should not throw away your jotters.
Now, briefly on what we call ST elevation. Now, please, I don't have a pointer here, but when we say a patient has ST changes, we look at the isoelectric point. Our isoelectric point is usually the TP segment, the interval between the P wave and the T wave. So somewhere here. So that will be our reference line to know if a patient has ST elevation or T-wave inversion is usually symmetrical T-wave inversion. The slope of the initial limb and the other limb is equal. So if you have this kind of T-wave inversion, you think ischemia. So these are other examples. We're going to talk about them. Now we need, for us to say significant ST changes, we need them to be present in consecutive beats, at least 3. Generally, for most leads, we need ST elevation of 1 millimeter. That's one small bus. I will talk about them. But for the chest lead, we may go up. We need at least 2 small buses above baseline. The ST changes must be present in at least 2 contiguous leads. Now, the leads on ECG are grouped. We have the inferior leads, usually 2-3 AVF. The lateral leads are 1 AVL, V5 to V6. The septal leads are V1 to V2. Anterior leads, V3 to V4. Generally, rarely do you just see septal and anterior separately. It's usually an anteroseptal kind of thing. So V2 to V3. So when you see changes in V2 to V3, you say it's anteroseptal. So this is just a graph showing the causes of chest pain. We have cardiac chest pain, which can be ischemic. It could just be stable angina. It could be acute coronary syndrome, where you have unstable angina or myocardial infarction. There are other non-ischemic causes of cardiac chest pain, like pericarditis, valvular disease, or aortic dissection. They are equally important. Of course, we have the non-cardiac causes, like gastroesophageal causes, and non-gastroesophageal causes like pneumothorax, pulmonary embolism, musculoskeletal chest pain is common, and of course, people can have panic attacks, and that will present with chest pain. So we have our first case, the one we presented earlier. Based on this now, I've presented this. We had a good spread. The next poll is, do you think the history and clinical exam we presented earlier is adequate for this patient? Please use the poll. Because of time, we just give one more second. So approximately 2/3 thinks the history is not adequate. So this was the ECG of the guest. We call our patient guest in my hospital. This was the ECG that was done.
So was the history adequate or not? What was the answer to the question?
2/3 of
were correct.
The history was okay. The patient had a sharp pain. The sharp pain, though it's retrosternal, is positional. It has to do with change of posture and all that. The patient does not have known cardiovascular risk that is significant. Maybe it takes occasional substance, but still, the troponins and all that were okay. The vitals were not remarkable. So I think this history is okay for that patient. The other thing is this ECG here.
Yeah.
The ECG here showing certain findings. I will show you this. You can see that the PRO segment here is depressed. It's pointing downward. And there, especially in the lateral leads. This is very specific for acute pericarditis, where you have PRO segment depression. It's one of the earliest findings in acute pericarditis. So there are some ST changes. They look concave, but they are not that elevated. So, but this is acute pericarditis with very specific ECG finding, which is PRO depression. So the result of the investigation of the patient, the ESR was 30 millimeter per hour. The full blood count was not remarkable. His LDL cholesterol was 124, which was a bit high. Total was also a bit high. The triglyceride was really high, maybe probably because of occasional alcohol intake. The electrolyte urea creatinine was fine. Fasting blood sugar was okay. No abnormalities on urinalysis. Troponin was normal. A stress test and exercise ECG was also negative. So based on this, the final diagnosis
for that patient.
For that patient, what's the final diagnosis?
There's no poll on this one.
There's no poll, okay.
So we'll just go ahead. We are running out of time. Please put that cursor back on. It's not working. The clicker is not working.
Okay. So why do we think it's not unlikely to be acute coronary syndrome? Straightforward. The characteristics of the chest pain. The ECG that was not pointing to significant ST changes or symmetric T-wave inversion. The normal troponin. This is not likely to be acute coronary syndrome, which we are going to discuss later. What's going on?
Hello, what's happening there, please?
Okay. Now, for acute coronary syndrome, we have three disorders under it. We have unstable angina, in which the patient presents with chest pain that is likely cardiac. Usually, we talk about it being an unprovoked or prolonged episode of chest pain that raises the suspicion of acute myocardial infarction, but we don't have what? A positive ECG, and the cardiac enzymes are normal. We also have non-ST elevation myocardial infarction. In this case, the chest pain is suggestive of myocardial infarction. We don't have ST elevation, rather we have ST depression, T-wave inversion, and we have a normal troponin level. Then, of course, we also have the third, which is ST elevation myocardial infarction. We have symptoms of myocardial infarction like severe chest pain, diaphoresis, feeling of impending doom, nausea, vomiting. These patients have ST elevation, new ST elevation on their ECG, or a new left bundle branch block, and the cardiac troponins are elevated. Could you change the slide from your side, please? I'm struggling with this. Okay. So we have a universal definition for myocardial infarction. The clinical definition for myocardial infarction denotes presence of acute myocardial injury detected by abnormal cardiac enzymes in the setting of evidence of acute myocardial ischemia. Next slide, please. So, our first knowledge is that every patient that is coming to you with acute chest pain must have an ECG within 5 to 10 minutes. On arrival to your hospital, be it the emergency or whatever setting you are working in, you need an ECG.
So just to add, ulcer too. Any adult coming with ulcer should have an ECG. Please, all those ulcer that, like you saw the case that we presented, she has been managed for ulcer for many years. Meanwhile, she's been having obstruction, okay? And then now came with ulcer again. So in Nigeria, ulcer too should be considered. Chest pain should be considered. Once they have chest pain, please, when you go back to your hospitals, go and bring out the ECGs from where it is locked up, so that it doesn't matter what time the patient comes into the hospital, they can get an ECG. It should not be locked up in a special place. It should be accessible to everyone at a particular time.
Okay. So this is the second case.
We'll jump. I think we'll just jump because of time.
This one, okay. That's fine. Let's jump this. This another ECG of pericarditis. You can see the PR depression are more widespread now, especially in the lateral and inferior leads, as I pointed out earlier. Because of time, we're going to rush through this. Yes. So this is this is a table showing how to make a diagnosis of acute coronary syndrome. If you have typical symptoms of unstable angina, that is more prolonged chest pain that is likely cardiac, or worsening chest pain, but you have negative enzymes and non-remarkable ECG findings, you think of stable angina. If you have symptoms to suggest cardiac chest pain or myocardial infarction, the ECG is not showing ST elevation, but rather ST depression or T-wave inversion, you think STEMI. And if you have positive enzymes and ST elevation, you take STEMI. Of course, if you have atypical chest pain, or you are not sure of the type of chest pain the patient has, and there are negative enzymes, but you are seeing some ECG changes, you are not sure, you may think STEMI, you may think pericarditis. The algorithm is that you repeat the enzymes in 6 to 12 hours, check for dynamic ECG changes by repeating the ECG. You also have to exclude some more dangerous things like ventricular aneurysm, complicating a recent STEMI more than 2 weeks earlier, because left ventricular aneurysm is a cause of persistent ST changes, particularly ST elevation. So, in the setting of clinical suspicion of acute MI, we think acute coronary syndrome. ECG in STEMI typically shows all other signs of myocardial ischemia, as I pointed earlier, ST depression and T-wave inversion. Okay. So, based on the results of the second case, we made an assessment of acute pericarditis. We didn't activate cath lab. The patient was placed on bed rest, had NSAIDs, antibiotics. Day 4, he was less breathless with minimal chest pain. Oxygen saturation was better. DSR had reduced, and the total white cell count came down to 4.8. The ECG after the treatment was better, though the heart rate is now okay. The ST depressions are better. The ST elevation, I mean the PR depressions are better now. So chest pain that is retrosternal in nature but pleuritic and positional. Pleuritic is that is relieved by sitting forward, worse on lying down. It's usually characteristic of acute pericarditis. They usually have widespread ST elevation and PR depression throughout most of the leads. There is minimal or normal cardiac enzyme elevation. Remember that it could be a late complication of STEMI, like we had a guest recently that developed acute pericarditis after treatment for acute coronary syndrome. So the stages of the ECG, I will not disturb you with
I think we can move past
this because we are still going back.
Let's go to acute coronary syndrome.
Yes.
And then,
so these are some other causes of ST elevation. Now this is also important. Cardiac enzymes are invaluable in the evaluation of chest pain. A negative troponin in the appropriate patient should be repeated 6 to 12 hours later.
How many of us remember the case that was presented by, I think it was Dr. Fatima? Remember that the troponin from the referral center was 0.1. By the time we repeated it was 23. So in the US, up to 10% of patients are wrongly discharged from the ER and say that they don't have MI. Meanwhile, they have almost life-threatening. 10 to 13% of patients are wrongly discharged from the ER in the US. So you can imagine in Nigeria, I don't know what that number will be. But this is one of the things why you have to do this thing and repeat again within 6 to 12 hours. So if it's normal and you are still short, those with high risk, repeat the ICG within 6 to 12 hours, repeat the troponin within the 6 to 12 hours. If you don't have troponin, what will you do? Pray? I don't know. But this is the standard. In current day, this is the standard. So you need to make sure you have availability or you have where you can get it done. I've seen a patient that was in hospital in town, had massive chest pain. They did an ECG, they did not review, they sent for troponin. Troponin result came out 3 weeks later. Then they now saw that the thing was high. It was that time they were not referring the patients. You can just imagine, 2.5 weeks later. So that is not what we're talking about. It's not a test that you do and then you send the patient to go home that you're waiting for results. No. It's a test you want to get the result 1 hour, 2 hours, maximum 3, 4 hours. Okay, very important. Or refer the patient.
We have a third case, but we're not going to go through it because of time. But the important thing for this third case is this. Cardiac enzyme elevation is not equivalent to acute coronary syndrome. Your clinical history and ECG findings should guide the interpretation. This is very important because we've had cases where patients will have mildly elevated cardiac enzymes that persisted for some days and they don't have acute coronary syndrome. Why? Because they don't have a typical history, the ECG is not showing, ST changes are in contiguous leads like 2-3 VF or lateral leads as we pointed out earlier. So because we have other causes like pericarditis, acute myocarditis, left ventricular aneurysm as I pointed earlier, that can cause ST wave changes, and you should not just take the cardiac enzyme alone as being diagnostic of acute coronary syndrome. So that's the third nugget. So we're going to focus now on acute coronary syndrome. Now, these are known as heart attacks. So everywhere you say somebody has acute coronary syndrome, we're just saying the patient has a heart attack. It comprises of unstable angina and myocardial infarction. Generally, it's atherosclerotic, that is caused by fissuring or rupture of an atheromatous plaque on the coronary arterial wall. What this means is that people over time have deposits in the arteries, in the coronary arteries, fat deposits that become hardened, but some of these deposits form plaques that can rupture later and cause thrombosis and occlusion of the artery. It's a medical emergency and appropriate care is measured in minutes to hours. So it's something that you have to decide on time and institute appropriate treatment. So we classify it into those that are not.
It's very important, very, very important. Minutes. We are talking about diagnosis in minutes and treatment in minutes to hours. This is not the patient you want to go and open card for first. This is not the patient that you send to go and buy drug in the pharmacy and come back. you should be able to make that diagnosis and treat within minutes to hours. Up to 50% of patients can die within the first 6 hours of the chest pain. So you don't want to lose time. We want to get them to the cath lab or to have treatment within 3 to 6 hours. Best, shorter time the better. Every minute that you are delaying, heart muscle is dying. Every minute you are delaying, trying to do something, all of that. So minutes to hours. Please, this is extremely important. Extremely important. This is not the one that you say, okay, when you come the next morning, you will refer the patient. No. If you don't know what to do, refer the patient immediately. Get the ECG immediately, interpret it, get the troponin enzymes. Sometimes the ECG alone is enough for you if you don't have troponin. So you want to do it as quickly as possible, minutes to hours. Please and please, it is very, very important. These are not the patients you tell them to go home and come back. No. These are patients that you want to treat, you want to get your diagnosis immediately. If you don't have the facilities, you need to be able to at least find these things. Please, I don't know how much else to explain it. Make sure that you are writing, please. Get a pen and a paper. We have a book there. Some of the algorithms are there, but a lot of things are not there. So please make sure you are writing. Try and resist the temptation to be on your phone.
Now we have this classification. We have those that are not treated with ST elevation. That's, we call them non-ST elevation acute coronary syndrome. Then we have the ST elevation myocardial infarction. The non-ST elevation acute coronary syndrome are divided into two: unstable angina. Then we have non-ST elevation myocardial infarction. Now for the unstable angina, as I said earlier, usually you talk about it in the context of somebody either with a known history of stable angina. This patient has typical chest pain less than 10 minutes in the past. But now they are coming with more prolonged episodes, more frequent episodes, or a new severe episode of cardiac chest pain. You're thinking, oh, this is likely acute myocardial infarction. But you did the ECG, there are no significant ST elevation, and the laboratory evidence is showing no elevation of cardiac biomarkers. You think unstable angina. Now for the other one is non-ST elevation myocardial infarction. This patient has features of myocardial infarction. Chest pain that is severe on presentation, usually upward of 20 minutes. They are diaphoretic, they are feeling of impending doom. They may even have features of heart failure on presentation. You think this is acute MI. You did the ECG test, ECG, and there is ST depression, as we showed earlier. T-wave inversions could even be normal, but you did the lab workup and you see that the troponin levels are high. You think what? Non-ST elevation myocardial infarction. For the ST elevation myocardial infarction, similar chest pain to the non-ST elevation myocardial infarction. Now this patient has new onset ST elevation in 2 or more contiguous leads, or new onset left bundle branch block, and the troponin levels are high. You think this is what? That's ST elevation MI. So we've talked about this earlier, so I'll skip that. Now again, to re-emphasize, all adults complaining of chest pain or discomfort or quote and unquote ulcer must get an ECG within 5 minutes. Max 10 minutes of presenting to you in the emergency. There's no exception. I had a colleague, a consultant that traveled to the UK for an exam, and she had a panic attack. So but the friend just rushed her to the emergency. There and there, they did an ECG, did the initial cardiac troponin that was negative, but they still kept her. They kept her because she's been hypertensive and diabetic. So they kept her in the emergency, repeated it at 6 hours and 12 hours before they discharged her and reassured her. Just to tell you the importance of this. You don't just dismiss patients coming with chest pain and say, no problem, don't worry, you are just worried, or you are having anxiety, or you have ulcer, and let them go home. And they must have troponin tests done. If they have any cardiovascular risk factors, and or if they have abnormal ST changes on ECG, please do the cardiac troponin. Now for stable angina, I talked about this earlier. Generally, we describe it against a patient with previous history of stable angina, but we have characteristics. If the angina is prolonged, because the typical angina is usually less than 10 minutes, but if it's prolonged, you are getting an angina that is occurring at rest, more than 20 minutes, a new onset of severe angina that is crescendo pattern, we call it, because we have residents here. The crescendo pattern means it's increasing in frequency, of longer duration, or is occurring with less activity. Maybe you used to get your typical angina with walking a 1 kilometer kind of thing, and now you are getting it with walking from your house to the gate. That we say is occurring at lower threshold. Of course, angina that is occurring after a recent episode of myocardial infarction. The patient had an MI before, is now having angina. Even if you don't have ST changes or elevated troponin, you class that as what? Unstable angina. Of course, we discussed this earlier too. Chest pain that is severe, more than 20 minutes, plus ECG changes, plus elevated biomarker is non-ST elevation myocardial infarction. Now, for a patient with non-ST elevation myocardial infarction, we can look at this ECG. Do we have anybody that wants to try and tell us the findings here?
Anybody wants to try? Well, we're going to do ECG shortly. You answer it by fire by force. I will come around and look for you.
Anybody?
Try now, try. Anybody? Don't worry, just teach them. They will get better.
So in this ECG, we have ST depression. We can see them here. ST depression here in lead 2, in AVF, and in lead 3. So we have generally in myocardial infarction, ST depression, we talk about it being either horizontal or down sloping. That's the typical one. The patient here also has some ST depression in V4, V3, V4, V5, and some V6 too. So this is non-ST elevation myocardial infarction. Patient obviously also had elevated troponin levels, but that's the finding there. So this is the typical pattern. But for ST elevation myocardial infarction, we've talked about this. The patient has clinical symptoms consistent with acute coronary syndrome, ECG findings, ST elevation now in 2 or more leads, or new left bundle branch block. Every new left bundle branch block should be considered as MI, unless there's evidence to suggest otherwise. Then, of course, they have elevated enzyme. Now, ST elevation can be tricky. For all the leads, as a rule, for most of the leads, is anything greater than 1 small box is significant. However, for the leads in the chest lead, particularly V2 to V3, we now have differences. For women, generally anything more than 1.5 small box, while for men, depends on the age. If they are less than 40, we talk about 2.5 small box as our cutoff for ST elevation in V2 to V3, and if they are more than 40, we just use 2 small box. But generally, if a patient has myocardial infarction, it's usually very obvious. So this is an example of ST elevation myocardial infarction occurring in the inferior leads. We can see the ST elevation in leads 2, 3, and AVF. The patient also has reciprocal ST depression in V2, V3. This is an anterior ST elevation myocardial infarction. We can see that in V2 to V3, the ST elevation is significantly more than 2 small boxes.
V4 and V5.
And V4, V5, V6, and all that. So
if you miss this ST elevation, you are not serious. So
yes.
you didn't come here. Don't just take your certificate. Hello? Can we see the ST elevation in this ECG? Perfect. So, and then we can see that anytime we want to see ST elevation, it must not be in only 1 lead. It must be in multiple leads. And those leads must be leads that are facing the same area. In this case, we can see almost from V1 almost to V5, V6. Then we also have 2, 3. No, I can see 1 and AVL. Yes. So you can see that ST elevation. Anybody coming with chest pain, you did this ECG, you are a nurse, you are a technician, you are a physiologist, you are a physiotherapist, and you saw this ECG and you told them to come back next week to see doctor. You are a killer. When you reach heaven, somebody will waiting for you.
Now, sometimes the patient is coming with a new left bundle branch block, and they have features of myocardial ischemia, that is severe chest pain. So because we have residents here too, generally for bundle branch blocks, sometimes in our own environment, we don't even know which is new and which is there before. Patients may have not done ECG all their life. But we have criteria to diagnose ST elevation in a left bundle branch block. Generally, we talk about concordant ST elevation. In these patients, we can even see the ST elevation in 2, 3, and AVF.
Let's leave it. Let's leave LBB for the floor.
Okay, so we'll leave that.
Let's keep it simple. If you see left bundle branch block, which I will show you, if you see left bundle branch, which is a wide QRS, as you have seen a very wide QRS, more than 3 small boxes, in a patient that has chest pain, please treat as MI. For the purposes of this meeting, treat as MI until proven otherwise.
So again, to emphasize, ECG within 5 to 10 minutes. Now, the first drug treatment should be within 15 minutes of presentation. You must do definitive treatment as soon as possible within the first hour, and then as soon as possible transfer and arrival at a center that can do the definitive treatment, usually a percutaneous coronary intervention like CardioCare, should be within 2 hours. You should do that within 2 hours. Every minute counts to that heart muscle and to survival of the patient. So you must make this decision on time. Now, how do we approach the patient? You have to take a quick history and examination. So you have to confirm that the symptom is that of typical cardiac ischemia, and you assess the hemodynamic status of the patient. Remember, I said some of the patients can become in shock. They may come in heart failure. Of course, we'll continue to say this: quick ECG and an initial cardiac troponin. You can see that we are not focused on doing an echo here, because you don't need an echo to say the patient has acute coronary syndrome. No. You just need the history, the ECG, and the cardiac enzyme. So, of course, you do close when the patient has presented, you are taking this acute coronary syndrome. Close monitoring. If the patient is hypoxemic, that is, they have low oxygen saturation, you have to give oxygen. Analgesic, usually we use opioids, but remember, opioids like morphine can induce vomiting, so you have to give antiemetic. Also, the illness itself can make them vomit. Glyceryl trinitrate, which is GTN spray, or sublingual or infusion can be used, especially if they have high blood pressure. Remember the warning about inferior MI and the risk of hypotension, that you try to avoid the GTN spray. Antiplatelets they are gold standard for anybody that's coming with acute coronary syndrome. You have to give a loading dose of aspirin, followed by 75 milligram. You have to load other antiplatelets like clopidogrel or ticagrelol or prasugrel, usually 300 milligram for clopidogrel, 300 to 600 rather. Then you continue with 75 milligram. Anticoagulants are also standard of care. We either use unfractionated heparin or enoxaparin at the doses that are stated there. So this is your initial medical therapy. Now, for the definitive therapy, you need to reperfuse their heart. And you must do this quickly. So generally, we have an algorithm to tell you how to go about it, depending on the capability of the hospital. But this is just a list of our options. The gold standard and first line is usually a percutaneous coronary intervention. And for some reasons, some may get only thrombolytic therapy or thrombolytic therapy initially before they can get to a percutaneous intervention. So the option are usually what? Alteplase, which is available in ABUJA, tenecteplase, and streptokinase. Streptokinase generally is not in most of the guidelines again. These are no drug, but in some parts, including Nigeria, streptokinase is still used. But in CardioCare, we use alteplase or tenecteplase at these doses. Of course, lastly, you can do coronary artery bypass grafting. Generally, in Nigeria, rarely do we go for this immediately in the emergency setting, because we still have some only selected centers that can do cabbage for patients in Nigeria. So it's usually for selected patients. Maybe they have a multivessel disease or they failed percutaneous intervention. But first line, just go for a percutaneous coronary intervention. Now, emergency reperfusion is what? Is the immediate priority. Remember, time is muscle. The longer you wait, the more chance that that heart muscle will not recover, and the more the chance of bad outcome. So you have to do this on time. There is an association between reperfusing the patient promptly within a 1.5 hour to 2 hours from first medical contact and more favorable long-term outcomes. So the goal is immediate coronary angiography with a door to balloon time of less than 1.5 hours. That's 90 minutes. What do we mean by door to balloon time? From the first contact to when the patient gets to the cath lab should be there are so many facilities in Nigeria that don't have percutaneous coronary intervention. So we have this algorithm. If you are working in a center that does not have percutaneous coronary intervention, if the anticipated time for you to transfer the patient to a center like CardioCare is going to be less than 2 hours, just transfer, because that will be better for the patient. Now, if it's going to be longer than 2 hours, you can do what we call a pharmacoinvasive approach. And what you do then is to give a thrombolytic first, then you transfer the patient for what? Percutaneous coronary intervention. So look at it. If it's less than 2 hours, just transfer the patient. The patient will still benefit. But if it's going to be longer than that, it's better you do something to save that muscle on time before the transfer. Because as we said, time is muscle. We don't want to waste time. So after the initial management for patients with non-ST elevation acute coronary syndrome, that's unstable angina and non-ST elevation myocardial. So this patient, after the initial oxygen therapy, pain treatment, giving anticoagulant and antiplatelet, we generally do a risk stratification for them. Thrombolytics are not indicated in non-ST elevation acute coronary syndrome. You don't give oteplase, tenecteplase, and all that. It's been shown to cause more trouble. Patient has increased risk of bleeding without benefit to the heart. So don't give thrombolytics. And that's why you need to know this ECG. You need to know how to make diagnosis of myocardial infarction, acute coronary syndrome in general. We don't give thrombolytics for non-ST elevation myocardial infarction. Give the initial therapy, re-stratify the patient. If they are high risk, send them immediately for coronary intervention, usually percutaneous coronary intervention, but in some cases, coronary bypass, as I said earlier. So what do we mean by risk stratification? It's just used to time invasive therapy, that is coronary intervention in patients with non-ST elevation acute coronary syndrome. The risk stratification is usually done based on the way they presented and ECG changes. I'm going to focus on those that are high risk and very high risk. Generally, if a patient is coming with hemodynamic instability, they are coming in shock, you understand, or in heart failure, and you think this is from acute coronary syndrome, there is non-ST elevation acute coronary syndrome, send this patient for immediate coronary intervention. If they are coming with ventricular arrhythmias like ventricular tachycardia or fibrillation, send them. Patients that we are treating with initial medical therapy and the pain persists, you understand, or they have what we call angina equivalent. What are angina equivalent? Remember that when we were talking about chest pain earlier, I said when we say there are patients that can come with atypical chest pain, we said even if it's atypical, we don't dismiss chest pain. So some patients come with what we call atypical chest pain or other symptoms suggestive of myocardial infarction that is not related to chest pain, like dyspnea. We had a patient recently that his only symptom was that, doctor, I used to walk out every morning. Before I walk this distance, but now from this distance to this distance, I get very breathless. And on coronary angio, he had extensive occlusion of his arteries. All the vessels are occluded. So such patients will say they have angina equivalent. They are presenting with dyspnea, not even chest pain. So if you think the patient is having medically refractory angina or angina equivalent like dyspnea, syncope, send them for what? percutaneous coronary intervention. Those are signs of high risk non-ST elevation myocardial infarction. So there are some that are high risk too, but you can send them within a day. Generally, we have some risk scores, but I think it's beyond the scope of this presentation. They are still based on the way the patient presents, the ECGs, and other high-risk features. So for secondary prevention, this is very important. Generally, secondary prevention, you have to tell them on diet. That's after, what do you call secondary prevention? Patient has had MI and hopefully has had the necessary intervention. You don't want a recurrence. Now, myocardial infarction or coronary artery disease generally, they are not benign disorders. Reason is this: the process that led to it is in other vascular beds in the body, in the heart, in the brain, in the kidneys, and all that. So the patient is not just at risk of a repeat myocardial infarction or ischemic heart disease. The patient is at risk of what? Vascular events in other organs, including risk of stroke, risk of kidney issues, risk of peripheral artery disease, and all that. That's why secondary prevention is very important. You want to prevent both a repeat of ischemic heart disease and atherosclerotic cardiovascular disease in other organs too. So lifestyle modification is always the first. You must place on dietary advice, low sodium, low fat diet, high fiber diet. Cardiac rehabilitation is just a program we use for most of our cardiovascular disease patients, include exercise program, diet, counseling, and all that. Exercise program is there. Smoking cessation is very, very important. So you have to do that for all patients. Now, this is also important for our general practitioners and our residents and physicians, doctors generally. All patients as part of secondary prevention should be on lipid lowering therapy. The standard is high intensity statins for all patients. By high intensity, we are talking about atorvastatin of 40 to 80 milligram, rosuvastatin of 20 to 40 milligram, and others. So they must all be, except they can't tolerate it, you must give them high intensity statin. Generally, you check your LDL cholesterol. Emphasis on LDL cholesterol. That is what we use as our target for therapy in secondary prevention. So generally, if you are not getting a target, the target is variable, but most guidelines talk about it getting, if your patient has suffered an atherosclerotic cardiovascular disease like stroke or myocardial infarction, you want it to be less than 70 milligram per DL, or a millimole, that's 1.8 millimole. So you want less than that. So in 4 to 6 weeks, if you are still getting something more than that, you can add other non-statin drugs like ezetimibe, or what we call a PCSK9 inhibitor as needed. Some of these drugs are now available in Nigeria.
That's inclisiran. I think Novartis presented that yesterday.
Yes.
It's a parenteral drug. It's given twice a year. Injection. It's twice a year. It's quite expensive. It's over ₦1 million. But it works in addition to your statins and tries to bring down that cholesterol very low. So it quite works, but it's quite very expensive. So sometimes we do it once a year, but also twice a year. Just give the person injection. They will still continue their statins, but it helps to bring down that LDL. All right, let's round up.
So I'm rounding up now. So that's secondary prevention. Antibiotic therapy. In our center, we tell patients you must be on, if you forget anything, you must not forget your dual antiplatelet. If you had had an intervention without being regular on your dual antiplatelet, the stent can be blocked, and you may present with a repeat. So we tell them you must use this. Some patients that also have concomitant atrial fibrillation. Generally, we don't give dual antiplatelet with anticoagulants. We just use single antiplatelet with the necessary anticoagulants. So, of course, if patient has need for other drugs like beta blockers, you give them that's angiotensin converting enzyme inhibitors, angiotensin receptor blockers are given in those with, especially in those with heart failure, which reduce ejection fraction. Also with mineralocorticoid antagonists for those with heart failure, which reduce ejection fraction. So I think we'll round up here. We expect a lot of questions. Thank you.